the birth plan. Birth plan is an empowerment tool, or it is something which gives you a power to take decision about your care. Is it working? Okay, so it gives you power about your decision. So it's normally it could be a blank page, or it could be a standardized checklist. This will be having the listing. In Saudi German, we have a birth plan which has listings, and listings have options. Like everything has 2-3 options, so you don't just take it. You will read through it, you will go, you will research. If listing is saying that this is the membrane has to be ruptured or not, how membrane should be dealt, when it should be ruptured. So you will do a little bit research, and after that you will have a pre-labor consult with your doctor, and then you will discuss with them, and then whatever you did in Google, it could be right or wrong, but you will just go and discuss with your doctor that I chose this. Is it the right choice? And if it is not the right choice, in my case, tailor-made to me or customized to me, what is the right choice and what is the alternative which is closer to my choice? Now we'll go through the birth plan. Recently I was making a video for the hospital about the birth plan, and then I just realized the people around me didn't know birth plan. So because we are a doctor, we think people know things and we just give the birth plan to the patient. But honestly, a lot of people, they don't know that they can practice autonomy, they have a right to choose during labor and delivery. So let's do the birth plan. So birth plan, nowadays, the modern women, she doesn't want uncertainties. She doesn't want unpredictabilities. They don't want surprises. They don't want to be suddenly in a situation where they don't know anything. They want to know everything before they go in any situations. So before embarking on any experience, it's always better that you need to know what is there, what is about to happen. And what is informed decision? Informed decision is something very medical term, because when patients come to us, they might be knowing what they might want to choose, but they can't choose without knowing what are the options. So when doctor explains everything about the options and then you take decision, this is called informed decisions. So it's a tool of empowerment. There could be two kinds of birth plan. One could be complete blank pages, another could be standardized listing with the options where you only have to tick off options which you want to choose. So of course you will learn the listing before you tick the options, and you would discuss those in early consultation, which is pre-labor consultation at 36 weeks with your doctor. And that will really give you a feeling of empowerment and autonomy. So the process is that you get a birth plan in a pre-labor consult around 30 plus to 36 weeks. You go home, you tick off the listings, you come back in pre-labor consult at 36 weeks, and you will discuss with your doctor. Doctor may explain to you why you're choosing what, and what according to your case will be the right option. So you will be prepared. You will not be in labor room like you don't know anything. You'll be really prepared that what you are doing, and you will feel confident in decision making. It's not just it's something which makes your bond with your doctor more stronger, more communication. It's a two-way thing. A silent doctor cannot communicate to you the birth plan. Doctor will be communicating, you will be talking, you also cannot be a silent person. So it improves communication between the doctor and the patient, and this gives the best chance of doctor and patient knowing each other, and they can decide together. So one is early communication at pre-labor consult somewhere around 36 weeks. Another one is real-time communication that happens when actually it's your big day, when things are happening. If there's something changes, doctor is coming to you, she is explaining why she broke your water. Even you wrote that water doesn't have to be broken earlier, let it happen spontaneously. So if they are deviating also from the plan, they will be explaining real time when you are in labor. So this is called collaborative decision making. There is nothing one-sided, everything is two-way. So mutual understanding and respect. Yes, you feel that your doctor chooses to respect your options, and your doctor want to give space to whatever you are thinking is right for you. And it's a personalized and customized approach. But sometimes what happens that your plan doesn't go the way it should, it deviates. So that should be explained in the early communication at 36 weeks, and that has to be again explained if it's happening at real time when the things are actually happening. Even with the deviation, doctor need to practice empathy and support, and there should be transparency and honesty. Even alternatives offered should be closer to the options you take. Say suppose you said you want skin to skin contact, so even you end up cesarean section, even in cesarean section doctor can provide you skin to skin contact earlier. Aftercare and debriefing, especially if there has been deviation from your birth plan, there has to be an aftercare. Their doctor should come to you and explain to you why they didn't follow your birth plan. Feedback and learning, actually always give feedback to your doctor. This is their chance of also to learn from you. And even making the birth plan, it should be flexible, better, tailor. It is personalized and customized for everybody. But be flexible, don't be rigid on the things. It can harm you, because sometimes doctor has to take, sometimes it's the question of the safety of the mother and the baby. So if your doctor is deviating, always listen to them and be flexible. And expect there could be unexpected things, because all labors are not similar. And still maintain positive outlook whatever happens, because you will have your chance to know why your doctor deviated from the original birth plan. Because everybody is meant for a positive birth experience, not to have an experience which they call birth traumatic experience. So what are the key elements of the birth plan? You can choose labor preferences, you can choose delivery preferences, medical interventions, and cesarean birth, whatever has to be done there, post-birth care and newborn care. So labor preferences are what? Pain relief option. Pain relief option, some people choose to go natural pain relief, some people choose directly epidural, but still my advice is that always go step ladder pattern, choose the minimum hypnobirthing or the breathing exercises and slowly go up. And even epidural, it's nowadays everybody goes for epidural, because I don't see the new generation has a lot of tolerance for pain, so it's completely fine. Still, it's a normal labor. Then labor position, normally traditional on back position. Most of the hospital staff in the world is trained with the traditional on back position. They have ease of maneuvering, but still you can choose upright position or birthing ball for the labor positions we are talking. Then fetal monitoring preferences, there could be continuous monitoring and intermittent, but if you are high risk, doctor may not give you the option of intermittent monitoring. Say suppose your previous C-section or growth retardation in the baby or any risk factors, they may not give you option of continuous monitoring. Then delivery preferences, you can choose who will be there in the labor room with you. You can bring your doula, you can bring a family member or friend, but partner is the best person to be around during labor. Birthing environment, this is your space, completely your personalized space. You can choose the lighting, you can choose music, you can choose aroma therapy. And delivery assistance, you can talk about the hands-off, hands-on approach. You can talk about episiotomy or the natural tearing, whatever you want to choose. And doctor will explain to you whatever they are choosing, why they are choosing, what are their reasons. Induction of labor preferences, there are a lot of options and you can choose from them. You can discuss with them, and not everybody needs induction of labor. Use of intravenous infusions, medication, antibiotics, augmentation, and avoidance of certain interventions unless medical necessary. Normally, we do not do interventions except if they are indicated. Normally, we do avoid interventions. Cesarean birth, you can choose to be awake or asleep during the procedure. Your partner, yeah? Somebody is already in labor. He's asking that, they're asking that what is augmentation? If somebody is already in labor and then we are increasing the labor pains by meds, this is called augmentation. Yeah? Increasing the labor pains by meds. Exactly, especially by the drips, oxytocin. Yeah. So, then partner presence during,
I saw that it's already clear on the slide, but for normal delivery, do you allow adelaide cord clamping?
Of course we do, but your baby should be completely all right. If baby is coming with some distress and we are not listening, we are seeing some signs, it's flaccid, then we will not wait for the cord clamping. Cord clamping has advantage of increased blood in the baby. But here, if the baby is flat, then there will be its golden minute of being resuscitated. So if there are indicators which will harm the baby, we immediately cut the cord and hand over the baby to the pediatrician. But if baby is in a good state, then we allow completely.
What is the maximum time?
It should be 1 minute. More than 1 minute, scientifically, we do evidence-based also. So we also explain whatever the options which you guys choose, that what is evidence-based. So delaying more than 1 minute, it's not wiser. Yeah, welcome. So then even in the theater, our theater is very chill. You will find a lot of videos around about the operation theater. It's a very relaxed environment. You can even choose music. Husbands are there, sitting there. Some husbands choose to be just behind the curtain with the wife. Some husbands just get up and start seeing surgery. Some go to the to see the baby. I mean, they're just moving like us inside the theater. Then post-birth care, immediate skin to skin, yes, we do support delayed cord clamping, early breastfeeding preferences, and placental delivery. You can discuss them all because we all are different doctors. We might be having our own practices also because we all, being in Dubai, everybody has been trained in a different place. They have their own experiences, years of experiences. So you have to discuss with your doctor what they educate and what is their rationale, not to educate something on to educate something. Yeah. Newborn care, yes, rooming in so is available. There's a nursery available. Some moms think they did a lot of hard work, enough. They want to sleep. We totally allow them. Some women think that they should take the baby and they should take care of the baby themselves. We support everything. So screening and vaccination, I saw Dr. Shata. So our newborn consultant, pediatrician, they will be there too. You can ask them the questions also, like about first bath, circumcision, eye ointment, and vitamin K. So birth plan should be decided in pre-labor consult better, and there shouldn't be any surprises, like don't suddenly in the labor table say that doctor do that and do not do that. It's not recommended. It should be discussed and decided, and doctor might need to do the research beforehand to see the safety of the options which you are choosing. And final thought, flexibility is the key, and there shouldn't be unpredictability in both sides, on the patient side and the doctor side. You should be open to the changes because not all labors are similar, they can be different. And regularly review and update your birth plan if you find something, if you new risk factors arising, if you're ending up induction. So you can keep updating, and you can discuss those changes with your doctor also. And there should be more discussions with the healthcare team. Yeah, this is my personal actually. Yeah. Any questions? Would love to, either everybody understood everything. Yeah. Mm-hmm. Okay.
So now my son's already 10 years old. So I want to take a natural birth.
Yeah, you can.
It's possible.
We all are allowing in my hospital, as far as I know, everyone is practicing vaginal birth after cesarean section. Only recommendation is that you should take all the labor in the hospital, and we don't do induction. Labor should come naturally. For that also doctor can help you by sweeping, by do the mechanical induction by Foley, but all the labor pain should happen in the hospital, not at home.
But it's possible, doctor. I was a natural birth. Then after that, the pain is really, I cannot take it. So can I take late for the epidural?
Yeah, epidural is your choice. It's just like somebody has a pain, they choose to take analgesia or not. So it's your choice that you want to take analgesia or not. So epidural is not, it doesn't come in the way of vaginal birth after C-section. It doesn't affect it. You can choose any time. That is your option. But vaginal birth after cesarean section is a real valid option, and it is happening.
So it's okay, it's a late to say to my doctor that I want to take a epidural, or right away the time that I normally.
It doesn't affect your labor. You understand? I will tell you. It can make your first stage smaller. So you will have advantage there. First stage, when you're becoming till 10 centimeter dilated. But later on, the second stage, it can delay. So doctor have their own technique how to make this okay. If your CTG is okay, everything is okay, even the second stage being longer doesn't affect. But if your CTG is not being all right, then doctor will do something to make your second stage shorter. But it doesn't, overall when you see epidural doesn't affect the length of the labor. So taking earlier has actually more advantage, but you should be in established labor. You should not take it with the induction of labor. You should be in labor before you take the epidural. Yeah. I read a book recently, it's a Birth Without Fear. I got it from Harvard store, and it talks about a woman who has 2 cesarean section and that she has 4 normal delivery. But she did a very big mistake. The book is amazing. She has a whole forum, she has a podcast, and she's really amazing. The whole things she's writing in the book is amazing, except one thing. She created a term which is not a medical term, home birth after cesarean section, HBAC. which is totally wrong. Yani medically something, and she expresses that. Anybody heard that they said that, what is that? How come you can take a home birth after 2 C-section? That's a big mistake. So we don't go very radical stuff, but home vaginal birth after C-section is a real valid option, and it is totally indicated. If your all risk factors are normal, everything is okay, you can have it. Yeah. Yeah. Actually, some places there, she is asking that epidural is walking epidural, or it is you just lie down. Walking epidural might be available some places, but our epidural is mostly patient is just comfortable. I think walking epidural has some risk also, that still they'll be painful, but because it depends on the dose. So we target to relieve the pain. So normally patient is lying on the back, and they prefer also.
For example, if you want to have an active birth,
Yes.
do exercises and while you are in labor.
Exercises start at 36 weeks.
No, I mean like the movements. Like
Yeah.
While you are in labor, you can do like your movement, like to walk around or so.
You know, I will tell you that depends on the intensity of the labor. If you are really in labor, you will not think about it. You want pain relief, you know, like there could be the intensity. I have people who are walking 6 centimeter. They're just walking and they're becoming 6 centimeter. But for some people, the whole journey goes while on the couch or bed, and then the drips are going on. It depends. If your labor is that one the going on and you are smooth, you don't need analgesia that much, you can do the birthing ball and all those stuff. But it depends what kind of labor. Labor has all shades of gray. You know, there could be. So you cannot relate the experiences which you heard in some conferences, ladies talking and explaining that they were doing. It depends what kind of, we have labors where women is just on the birthing ball and just actively moving, not demanding any analgesia. But some people have real labor when they are just can't move. They when labor comes, they just stop, and they even stop everything. The whole world stops around them and they can't do anything. So when these kind of contractions are coming very frequently, what you will do, you will say, you will just ask your doctor, enough, just give me epidural, let me just breathe. So it depends what kind of labor you have. So we give, normally epidural goes when the intensity is very high. Patient cannot tolerate. She is not thinking about movements or anything. So no, we have a lot of things. We have pethidine, which is something like morphine. We have Internox, which is laughing gas along with air. So we have a lot of options. So that is the reason I'm saying go step ladder pattern, like start from the breathing exercises and this and that, slowly go up. Yeah? Welcome. Yeah? Okay, in your in some pages, in social pages, you will read back pain. He's asking the epidural side effects. So in some social pages, you might hear back pain. Back pain doesn't happen due to epidural. It happens because mom is breastfeeding with the wrong posture. She needs calcium. She's exerting a lot. She's sleepless. So anybody in that situation will have back pain. Back pain normally doesn't happen due to epidural. And this is the reason most of the hospital staff goes, when they themselves are in labor, they go for epidural. If we would have seen something wrong with epidural, we will never go for it. I myself has epidural 17 years back, 2 epidurals, like 2 kids, and I never had back pain. So why it's a personal anecdote, but honestly, most of the hospital staff, they are not reluctant when they have to take epidural, they'll just go for it. So long run, there's no side effects on the, even in the short term, some people can have a bit of headache or something, but that's also temporary. Yeah, I totally recommend epidural, by the way.
Does it have any effect on the baby?
if the CTG is bad, like, and CTG is bad, and mom, just because she doesn't have pain and she's not pushing, and there's a delay happening, that can have effect, but doctor doesn't leave you just like that. If they see this is happening, CTG is not right, you don't have a, they encourage you, they time your contraction, they might decrease the dose of epidural to give you a bit taste of pain so you can push with that pain. So if your doctor is smart, there won't be any effect on the baby. This is the only implication which can happen, because it goes to a space, it doesn't go to your blood stream to be transferred to the baby. Yeah. Yeah. I'm enjoying this presentation actually.
I wanted to hear your view on like cord blood storage.
Cord blood
storage, especially if there's no like any like history of like any like diseases in the family, and like also no symptoms. Is cord blood something that we should consider? This is also like quite expensive.
It's very expensive. One thing, it's a bad side of it. In other countries, in US, in Europe, in India, there are private public banks, same like the blood bank. They treat this whole scenario like blood bank thing. Like you, if you are willing to go and give your blood, you give blood and you get the blood without even providing the donor. So when somebody gets those diseases in those countries, they go to the banks and they do the matching, same like your blood. And then when they do this matching, then it is not the one unit they need, they might be needing multiple units. So because we don't have such a thing here, so you know these private banks have the place, and I know people who are actually in need of that. And I have my son's friend's father who got suddenly diagnosed with such a disease, and his mom was telling that we didn't do that. So if we had it, so it could be not just son's blood, it could be used for anybody in the family.
I understand that, but if in case there's like no like any diseases in the family,
still, yeah.
And the other question is, you know, in case it happens, there's always the option of like, for example, moving to a different country and taking. I mean, these are extreme situations, right?
Again,
so,
yeah.
Yeah. So basically, I understand the point you're making. But in case there are no history of any of these diseases,
Still.
Right?
Still it can happen.
Right. It can happen. You could move to the other country and do it there.
If your country has that system, and if your more relatives, so if anybody has, like it should not be the one unit, honestly, it should be multiple units. And if people in the family have deposited there, especially the public banks, then you will have advantage, because there's more chance that you're matching with them. Blood, the simple blood, it's very easy. There are only few blood groups, but for that stem cell, the variation is wide. So it will be, if you can afford, then it's a good option. But you understand, like it can be used in the same family for anyone getting that disease, at least that one unit, which is very just one unit, but it will be just pure your match. So that has advantage, but the flip side is it's really expensive. So we don't force, like we don't live in ideal world, so we don't push everyone to do that, because cost is really, really high. So if you can afford, that is not just for your kid, this could be for anybody in the family, even for the cousins, it could be used. So, but it's an investment, investment means you deposit today, and there's a chance that nobody should get the disease, but it can happen. Like there are diseases which can happen without even the family history.
Understood. And regarding like the applications that we have currently, is that mostly like for the family, or is there also like for the baby itself? I heard like for the baby itself, there's very limited treatment, limited indications, and usually like it's also like like very anecdotal, like the knowledge that we have of it, or are we now like
I think
more
people are
advanced?
being treated like it is established. You know, I'm a person who is not easily convinced on everything. So, and then I saw examples because I'm very careful whatever I advise. If insurance not approving anything, I don't push my patient. Even double marker, I give choice to my patient that if you feel that you really need it, there this is the option, this is the alternatives, like why we are doing. So, you know, like it took me really longer to get convinced, but yes, there is advantage, but you don't know that you will need it or not. There are no predictors which can tell you at this point of time that who will need it, but it can be used for anybody in the family. Even for the cousins it could be used.
And do you know how long it usually is stored? Or like
It's actually, it is the package, no? Whatever you choose, like you chose 15 years and 25 years. I think representatives are sitting here, so they can explain actually how much long. So at the end of the lecture, just tell them that, yeah, she will, yeah. So this is the package, like, because they have storage place, but you buy how long you want things to be there, yeah?
Sorry
Okay.
for taking from the speech.
Yeah.
Okay.
Yeah. Yeah.
So, Doc, in the case of a normal delivery, maternity bands are allowed right away.
Yes, of course, of course.
Alright, so
If you are cesarean, I would say wait for the healing. If you're not cesarean, then
it's
okay, it's perfectly fine. But there is another school of thought: when you give the ease to muscle, then they will not get their tone back. So it's up to you. Like, you can do the exercise and get a mix of both. Don't depend totally on the belts. Do some exercises also of abdominal muscles and use belts also. And you choose the belt very wisely, because they should be really comfortable, not like that now you're eating food, you're removing it, now you're doing this, now you're removing it, and it's just short time. So choose them wisely, yeah. Welcome.
After after how many days? After how many days people use that belt?
It depends on the healing. Your doctor should give you the signal that yes, it's been healed and everything is okay. So if it's healed, if it's joined,